Greetings, everyone. My name is Amal Mattu, and I'm faculty here at University of Maryland, and welcome to our Crashing Patient Conference. For those of you that are interested in getting CME credit for the lectures that you're going to see, you can get CME credit on EMedHome. Check it out at www.EMedHome.com. And for those people that want live lectures, we're going to be right back here in October of 2013. Hope to see you then.
Good morning. My name is Larry Weiss. I'm a professor of emergency medicine here at the University of Maryland, and I hope you'll excuse my appearance, but I'm giving this talk immediately after the end of a very busy night shift. And we're going to spend a little bit of time now discussing defensive documentation. And I'm going to give this lecture from the perspective of a defense attorney. I actively defended emergency physicians in medical malpractice cases for more than 10 years. And everything I'm going to tell you is really supported by the literature, by the medical literature, risk management literature, and case law, as well as my own experience litigating. So my objectives in this lecture are to describe an approach to honest, accurate, defensive documentation, and for you to understand an approach where we routinely document in a way that we rule out the worst possible diagnosis. And of course, this coincides with national standards of practice. This is how we practice emergency medicine. Someone comes in with a headache, it's a subarachnoid bleed or meningitis till we prove otherwise. Someone has back pain, it's a Cotta Aquinas syndrome until proven otherwise. And I could go on and give you one example after another, but your documentation should reflect the fact that you're ruling out these most dangerous possibilities when you're evaluating even common presentations. And finally, we're going to take this approach and specifically apply it to the highest risk presentations in emergency medicine. Now, for those of you who attended the course last year, I went through a long list of general rules of documentation, and then we applied it to these 5 unstable presentations in emergency medicine. And we don't have time this year to go through all those general rules, but the handout is available online to those of you who are watching this webcast. So it's a 10 or 12 page detailed outline, and if you're interested, you can go through all these general rules, and the outline is very simple, it's easy to follow, and I hope you find it helpful. So this year we're going to look at really the 5 highest risk clinical presentations in emergency medicine according to dollars lost in litigation. This is the list. We're going to start by discussing adult patients with chest pain. Out of the tens of thousands of clinical entities that we evaluate in emergency medicine, this one entity, allegations relating to the failure to diagnose an MI, account for more than 1/3 of all dollars lost in emergency medicine litigation. So we'll talk about this entity in more detail than the following 4 entities because it really deserves emphasis and it deserves more time for us to go through all the nuances of a patient presenting with a possible acute coronary syndrome. And we have to step back for a minute and emphasize the importance of never missing one case of acute coronary syndrome. Our workup is not geared toward just diagnosing MIs. We really don't have to diagnose every MI. The only MIs that we have to immediately diagnose are STEMIs. So the emphasis in our approach has to be the acute coronary syndrome, and we have to have an approach where we don't miss one case of acute coronary syndrome. So, for example, cardiac enzymes have a sensitivity of 30 to 40% in diagnosing ACS because the other 60 to 70% of cases where patients have ACS, they have unstable angina. So we have to have an approach that really captures every case of ACS, and let's talk about that approach. And like I said in the outset of the talk, I'm giving this talk from the perspective of a defense attorney. So if someone alleges that you failed to diagnose an MI, what documentation do you need in your note to be able to successfully defend yourself in such a case? And whenever I give a talk on documentation, someone usually gets upset and says, well, my emphasis is on taking care of the patient and providing good medical care. That's my emphasis. But there's no reason why you can't provide outstanding clinical care and also have a note where you adequately defend yourself. And we have to have this perspective because we're practicing in a country where 75% of all attorneys practice. We're practicing in a country that has the world's most aberrant tort system, and it's a tort system that leads to endless, often groundless litigation. And if you don't have a way of routinely defending yourself, you're going to rapidly become uninsurable, and you won't be able to practice emergency medicine. And we have to remember that we're practicing in a relatively high-risk field, and this is risk number one, patients alleging that you failed to diagnose an MI. So I tried to list the most important points in red, but let me start with the first point, that this is an entity where time is of the essence, and you must document the time that everything happens. I would tell you that for the rest of your career, you should never write anything on a chart without documenting the time, because so much of what we do in emergency medicine is time dependent. But here we have all sorts of requirements. For example, that we should get the first EKG within 10 minutes of the time the patient hits the back door. The patient has to go up to the cath lab within 60 minutes. And there are dozens of other requirements that necessitate acting within a certain period of time. So it's really essential for you to document the time that you do everything when you approach an adult patient with chest pain. Now, most of what we read in the cardiology literature says that when we're done taking the history, our mind is made up whether a patient has to be admitted. That's because nothing is more sensitive than the history in diagnosing ACS. If you look at the American College of Cardiology position papers on chest pain, they'll tell you that the history opens the door to risk stratification. Okay, so the history is the single most important element of our initial evaluation. Now, the chest pain history has three major components: characterizing the pain, the risk factors, and the associated symptoms. And again, if we look at our literature and the cardiology literature, characterizing the pain is by far the most important element of the history. And there are quite a few good mnemonics out there. I would tell you to memorize one of these mnemonics. I would imagine that 95% of you already use an approach like this. I use the OPQRS2 mnemonic. O is onset, P is palliation. What causes the pain? What relieves it? Is this exertional pain relieved with rest? Is this pleuritic pain, positional pain? Q is the quality, with tightness, squeezing, pressure being most typical, sharp pain being by far most atypical. R is radiation, S is severity, T is time. How long does each episode last? Are there any other temporal relationships? For example, is this pain related to eating? And we could think of dozens of other factors that could affect the pain. So if you have such a note where you adequately describe the character of the pain, the risk factors, the associated symptoms, and you've got a decent exam and you've done a decent workup, someone may have a cardiac event a day later, a week later, a month later, unrelated to the reason why they presented on the day in question. They'll still try to blame you. If you're the last physician who examined that patient, they'll try to say that you failed to diagnose an MI, and whether or not your case is defensible is mostly going to depend on the quality of your documentation, especially on how well you documented the history. If this is a history that is not consistent with ACS, then your attorney can argue that no emergency physician in their right mind would have proceeded with a cardiac workup. That's an argument I used in at least 3 cases in the years I litigated, and we won all 3 cases. So that's often a winnable argument, but it depends on you having a defensible note. And certainly it goes without saying these notes have to be accurate and honest. Honesty is really the best policy in documentation as well as our clinical practice. So I hate to say that the exam is never important. The physical exam is always important, but relative to the history, it's not nearly as important. You still want to do a decent exam. The physical exam is most important in entertaining an alternative diagnosis. Sometimes your exam will lead you to make another diagnosis other than ACS, but document a decent exam. And let's talk about the workup. The most common allegation in these cases is the failure to diagnose an MI. The second most common allegation is misinterpretation of the EKG. The third most common allegation is negligent treatment. Now, why is the EKG so important? Well, there are a fair number of papers out there that show that the computer readout on the EKG is highly accurate. It's not 100% accurate, but plaintiff attorneys will cite these papers. Plaintiff experts will cite these papers at deposition and at trial. And so if you're going to disagree with the printout on the EKG, I've had many dozens of cases where it says acute MI at the top of the EKG with stars all the way across the top, and I know it's not an acute MI, and I'll explicitly state why in my note. So when we talk about documenting the history, the rest of your exam, the workup, we're not talking about volumes of documentation. It's the quality of what you write, not the quantity. But with that said, these are my longest notes because the history must be described in adequate detail. That's the single most important thing to document in these notes. So document why you disagree with the EKG. And let's talk about cardiac enzymes because, in my opinion, this is the single most important controversy in all of clinical emergency medicine, because this is the number one area of liability in emergency medicine, and it's compounded by the fact that we have two opposing standards of practice with regard to the use of cardiac enzymes. So there's a significant body of relatively new literature in emergency medicine that says, well, we can have a very low threshold for ordering serial enzymes and just throw that into the whole mix of risk stratification. And if the enzymes are also negative in someone who's low risk, that gives you a further decrement in risk. And I've read most of these papers, and most of them are well done. Some of them, though, include a population that's so low risk that regardless of what you did, you could send the patient home and they would do well. So I don't think all those papers really prove the point they allege to prove. But in the aggregate, these papers do describe I'd say a defensible standard of practice, but it's still a minority standard of practice when you look at the whole world of cardiology, when you look at emergency medicine as it's practiced now around the world. But a significant percentage of emergency physicians practice in this way. What I would still refer to as the majority standard of practice is to use cardiac enzymes when you're convinced that the history is consistent with ACS. This opens the door to risk stratification. You order enzymes and the patient should be admitted. If you order serial enzymes and send the patient home and they have a cardiac event a day later, a week later, a month later, the plaintiff attorney will find an honest expert who will testify that if you let the patient languish in your emergency department for 10 or 12 hours getting serial enzymes, that is strong evidence that you were convinced that the history was consistent with ACS. And if you were convinced this was a good history, you should have admitted the patient. And the whole act of getting serial enzymes, sending the patient home, is inconsistent. And this is what this large body of experts will testify to. And so if you have someone who's very low risk, and then you get serial enzymes anyway, I would argue that you shouldn't feel more comfortable sending that patient home, because that will magnify your risk. If the patient has a cardiac event not even related to why you saw them today, you'll get blamed for it, and an expert will say that if you got enzymes, you should have admitted the patient. So it's a complex issue. If you use the approach of getting enzymes as just another way to lower risk, even when the presentation is not consistent with ACS. There's literature you can cite. But I would argue in the long term, it's raising your risk, not lowering your risk. I recognize this is a controversy, and I recognize there's a countervailing argument. So let's move on to number 2. If you look at most papers that have looked at litigation risk in emergency medicine, number 2 is usually undiagnosed appendicitis or allegations that you failed to diagnose appendicitis. Most of these papers were published before the late 1990s. In 1999, we started to use helical CT scanning, contrast CT scanning to diagnose appendicitis. And in the right radiological hands, it's 99% sensitive. And so I think if we repeated a similar study today, that appendicitis would no longer be in the top 5. But when you look at our current literature, it's still listed as number 2 or 3 in most papers. So if someone alleges that you failed to diagnose appendicitis, what type of documentation should you have in your note? Well, again, document times. Because in a lot of these malpractice cases, if a patient has a ruptured appendix while you're working them up, they'll allege that you did the workup inefficiently, you took too long, you wasted time. So again, this is another entity where it's essential to document times. And the symptoms, the high-yield symptoms that I know you're familiar with: fever, nausea, vomiting, anorexia. If someone has diarrhea, that doesn't rule out appendicitis. It makes it less likely, but it doesn't rule it out. And on exam, the presence or absence of peritoneal signs, and then whether you proceeded to a further workup, and we already talked about the essential rule of CT scanning. And if someone has peritonitis in this day and age, in most cases, we're going to, send abdominal lab work and get a CT scan, usually with at least IV contrast. That's controversial, but that's probably the majority standard of practice. Now, I mentioned that failure to diagnose appendicitis is number 2 or 3. In cases where it's listed as number 3, the number 2 area of liability is undiagnosed sepsis or meningitis in a neonate. And, these are very scary cases because of how hard they are to diagnose. Again, the history is essential. And the pediatric literature is filled with references as to how important it is to ask the parents about personality change. If the child is listless, lethargic. On the other end, if they're hyper-irritable. They're inconsolable. These are very important symptoms. Behavior during the exam. Most kids cry and they get irritable during an exam, but if you can't console them, you see behavior that's otherwise atypical, that's important to document. If you have a fever without localizing signs, in most papers that's more dangerous than a child with a fever. You can localize the sign of infection. If the locus of infection is parameningeal, that should raise the risk. But otherwise, a fever without localizing signs should make the red flags go up. And you must document a detailed neck and neuro exam. And as I'm sure you know, you can document a pretty complete neurologic exam in a neonate. Not as complete as in an adult, but you can perform a pretty complete exam. Now, when I went to medical school, I was taught over and over again that when a child is greater than 9 months of age, they should reliably have meningismus. But on the other hand, 10 years ago in the Journal of Clinical Infectious Diseases, a well-done study showed that only 29% of adults had nuchal rigidity. Adults with meningitis, only 9% had a Koenig sign, and only 9% had a Brodzinski sign. But you should still document a thorough neck exam. If the child doesn't have a stiff neck, that should not dissuade you from the diagnosis. And so when in doubt, perform the whole workup. Blood cultures, CT, LP, CSF culture, empiric antibiotic until you get your cultures back. So let's move to number 4, failure to diagnose an ectopic pregnancy. Patients usually present with first trimester bleeding, sometimes just severe pain and no bleeding. But we're going to primarily talk about the first trimester bleeder. And if someone alleges that you failed to diagnose an ectopic pregnancy, the documentation you need in your note, their menstrual history, when was their last normal menstrual period. We used to think that painful bleeding was an important differentiating symptom, but you know, it really isn't. Like any first trimester bleeding should really lead you to perform a thorough workup. And on the physical exam, is the cervix opened and or effaced? If it is, you've got an incomplete abortion, and in most cases, the patient should be discharged after the uterus is evacuated. Are there any adnexal masses, adnexal tenderness? And then we should be getting a beta quant in almost every case and an ultrasound. And if the quant is greater than 1,500 units, we should see something in the uterus, either a yolk sac, other products of conception. And if the quant is greater than 1,500, the uterus is empty, it's an ectopic pregnancy until we prove otherwise. Remember to screen the patient for their blood type and RH, and if they're RH negative, they should get mini-Grogam treatment to prevent fetal high drops in the delivery period, the peripartum period. So let's talk about wounds, because wound complications is often included in the top 5 areas of liability. And for the most part, these cases involve allegations of failure to diagnose a tendon injury in the hand. You know, almost everyone has to depend on normal function of their hands in order to work. And so when someone shows up in front of a jury several years later with flexion contractures of their fingers, and they sit there for a week holding up their hand in front of the jury, it usually results in a large plaintiff verdict. So someone alleges you failed to diagnose a tendon injury. What do you need to have in your note? Well, you should describe the mechanism of the injury, and in your note you should state that all 3 layers of tendon function were intact. That tells an expert witness and ultimately a jury that you knew there were 3 different layers of tendons in the hand. You knew how to isolate each layer of tendons for normal function. You should also document that sensory and motor function to the radial, median, and ulnar nerve were normal. And again, that shows the expert witnesses that you knew how to isolate each of the 3 nerves for motor and sensory function. And my notes are, in a case like this, are 2 or 3 lines long. That I isolated all 3 layers of tendon function, that the sensory and motor function to all 3 nerves was normal, and that, you know, AB, adduction, flexion, extension, and opposition to the thumb were normal, and that covers all the intrinsic muscles of the thumb. And in a brief note like that, that's a comprehensive hand exam. The procedure notes are essential. You know, I had to defend a lot of cases where someone got a wound infection. They said our doctor should have given an antibiotic for an acute wound. And of course, there's never been any evidence that antibiotics are useful in preventing infections in acute wounds. The only thing that's ever been proven to be effective is vigorous irrigation, and that's what you should document in your note. You took a liter of normal saline, 750 cc's, whatever, under high pressure, 18 gauge, angiocatheter, whatever, you irrigated out the wound. It's not negligent to miss a foreign body. It's negligent not to look. So into your procedure note, you should document you thoroughly explored the wound. You look for foreign bodies. Depending on the history, you might want to ultrasound the area, look for a foreign body, get a plain film, whatever. You don't see the foreign body. You took all the necessary precautions. It's not negligence. So finally, let's talk about headaches. Let's talk about the atraumatic and then traumatic headaches, and we'll be done in a few minutes. So let's start out with atraumatic headaches. Describe the pattern. It's almost like angina. If an adult has a crescendo headache pattern, it should be investigated. But if their exam is totally benign, they may not need an emergent investigation. So is this someone who gets 1 mild headache a year and now they have 5 severe headaches in a week? Was it a thunderclap onset or a gradual onset? Any other focal or lateralizing neurologic symptom? Is there neck pain or stiffness? Is there photophobia? So, of course, the diagnostic triad for a subarachnoid hemorrhage is the thunderclap headache with neck pain and photophobia. When a patient has that, regardless of the exam, you're going to do a complete workup. So I talked about the fact we always consider the worst possibility until we demonstrate otherwise. With the headache, it's a subarachnoid bleed or meningitis until proven otherwise. You and I know that almost 100% of headaches that walk into an ED are benign. Juries don't understand that. They can easily be led to believe that only someone with a life-threatening headache would come to an emergency department. Plaintiff attorneys always say that. Most juries believe that, so the burden is on you to show otherwise, that this was a benign headache. So you document that the history is benign, you look in the fundi, and you do a complete neck and neurologic exam. That's all benign. In most cases, you're done. You can send the patient home with an appropriate analgesic and follow-up. So finally, let's talk about head trauma. And here, the patient has an epidural or subdural hematoma until we prove otherwise. They could have a traumatic subarachnoid hemorrhage, whatever. But here, we never want to miss a case of an intracerebral bleed. And so this goes back to the landmark paper of Masters et al. In the New England Journal way back in 1997. If a patient has no hard symptoms, by a hard symptom, I mean a symptom that correlates with an intracerebral bleed, the two hardest symptoms are loss of consciousness and post-traumatic amnesia or confusion, but also repetitive vomiting in a child, any vomiting in an adult, any focal or lateralizing neurologic symptom. So no hard symptom, a completely normal sensorium, and a completely normal, highly detailed neurologic exam, you're done with those patients. They can go home. That's 90% of patients with blunt head trauma. Okay? But if they don't pass this 3-step test, you've got to get a CAT scan without contrast and acute trauma to rule out a bleed. Now, it's a little more complicated than that. There are intermediate groups of risks, like the patient with a hard symptom who bleeds. And in a hospital where you can order a CAT scan stat any time of the day or night, I think the consensus is we should scan those people also. So if you have this kind of documentation, you'll probably never miss a subdural or epidural hematoma. There are freak cases, rare cases that occur where you've done the appropriate workup, where the imaging wasn't indicated, and if you've got that high quality note, you've got a defensible chart. You never want to miss a case because you want to do what's best for the patient, but we can't radiate the whole world. If you've got a high-quality note that shows that the CT wasn't indicated, you'll have a defensible chart. Even if you're sued, you'll be able to successfully defend yourself. So that's the dirty half dozen as far as high-risk presentations in emergency medicine. And, in the handout, I've got my email. You're welcome to send me any email questions. The purpose of this lecture was not to provide legal advice, but just continuing medical education, and proper documentation is a very important aspect of professional, clinical development. And so none of this was intended as, any kind of legal advice. So please contact me if you have any questions, and I hope this talk was worthwhile. Thank you.